For years, many people have pictured artery plaque as something like grease clogging a kitchen pipe. Cholesterol simply sticks to the inside until blood can barely squeeze through. But that familiar image leaves out an important part of the story. Atherosclerotic plaque is far more complex. It develops within the artery wall through a long biological process involving lipids, inflammatory and immune activity, cellular debris, and, in some plaques, calcium and other components. That distinction matters because an artery is living tissue, not plumbing, and plaque cannot simply be washed away like grease. So instead of asking what can magically clean an artery, a better question is, what is actually happening inside the arterial wall as plaque develops, and which parts of that process can realistically be influenced? To answer that, we first need to look at one component that often gets overlooked and understand what the evidence really tells us about fibrin. That overlooked component is fibrin, but calling it simply bad would miss its essential role. Fibrin is a protein involved in the body's normal clotting response. When a blood vessel is injured, a series of reactions helps transform fibrinogen, a soluble protein circulating in the blood, into fibrin strands. Think of those strands as part of a temporary biological net. They help stabilize a developing clot so bleeding can be controlled while damaged tissue begins to repair. Without a properly functioning clotting system, even ordinary injuries could become dangerous. But the body also needs mechanisms that remove clot material when it is no longer required. In other words, the important issue is not eliminating fibrin altogether, but maintaining a carefully regulated balance between forming and breaking it down. And that raises the next question. How does the body perform that cleanup without interfering with the clotting we actually need? So how does the body remove fibrin when a clot has done its job? It relies on a carefully regulated process called the fibrinolytic system. One of its key players is plasmin, an enzyme that helps break down fibrin within blood clots as part of normal clot resolution. This changes the way we should picture circulation. Your bloodstream is not a plumbing system that simply needs to be cleaned out. Instead, the body is constantly balancing two essential processes: forming clots when they are needed to limit bleeding, and breaking them down when they are no longer necessary. Both sides of that balance matter because too little clotting can increase bleeding risk, while abnormal clot formation can also become dangerous. But how can doctors learn more about this system from a blood test? One important clue is a protein called fibrinogen, and understanding what an elevated level may mean takes us to the next part of the story. One clue doctors can measure is fibrinogen, a protein made primarily by the liver that circulates in the blood and serves as the precursor to fibrin. During clotting, fibrinogen can be converted into fibrin, helping create the network that stabilizes a blood clot. A blood test can measure fibrinogen levels, and elevated levels may occur in connection with inflammation, and have also been associated with cardiovascular and clotting risk. But this is where an important distinction is often lost. A high fibrinogen result does not automatically mean that plaque is currently forming inside your arteries, nor can this single measurement diagnose atherosclerosis on its own. Doctors interpret laboratory results alongside symptoms, medical history, other risk factors, and additional testing when appropriate. So, rather than treating fibrinogen as a simple plaque meter, the more useful question is what factors may influence this broader cardiovascular picture. And that brings lifestyle and aging into the story. If fibrinogen is only one piece of the puzzle, what else shapes cardiovascular risk over time? Aging matters, but it does not act alone. Smoking, heavy alcohol use, chronic stress, poor dietary patterns, physical inactivity, and certain health conditions can influence inflammation, blood vessels, metabolism, or clotting in different ways. The key is not to place every factor into one simple category called inflammation. Association is not always causation, and cardiovascular disease usually develops through several interacting processes rather than one lifestyle mistake. Even popular claims deserve scrutiny. For example, saying that all seed oils automatically cause inflammation goes beyond what should be concluded without stronger evidence. The overall dietary pattern matters far more than blaming one ingredient. Instead of searching for a single culprit, the better approach is to focus on well-established risk factors. But this leads to another intriguing question. Can enzymes taken by mouth meaningfully influence fibrin elsewhere in the body? That question brings us to an important distinction. Digestive enzymes normally work inside the digestive tract, helping break proteins, fats, and carbohydrates into smaller components the body can absorb and use. But products marketed as systemic enzymes are promoted with a very different idea, that certain enzymes taken by mouth may influence processes beyond digestion, including fibrin-related activity. This is where we need to separate an interesting biological hypothesis from a proven medical outcome. Protein enzymes are large molecules, and questions remain about how much active enzyme can survive digestion, be absorbed, and produce clinically meaningful effects elsewhere in the body. Taking an enzyme on an empty stomach is sometimes proposed as a way to improve this process, but a proposed mechanism alone does not prove that it can treat atherosclerosis or remove arterial plaque. So, what does the research actually suggest? One of the most discussed examples comes from a traditional Japanese food, natto. That traditional food is natto, made by fermenting soybeans and commonly associated with Japanese cuisine. During fermentation, bacteria produce an enzyme known as natto kinase, which has attracted scientific interest because of its potential effects on fibrinolytic and cardiovascular processes. Some research has examined whether natto kinase may influence markers related to clotting, blood pressure, or circulation. But that is very different from proving that it can dissolve blood clots or remove plaque from human arteries. Studies vary in size, design, dose, and duration, and important questions about long-term clinical benefits remain unresolved. That distinction matters. A biological effect or change in a laboratory marker does not automatically translate into fewer heart attacks or strokes. Natto kinase is therefore better viewed as an area of ongoing research, not a proven plaque-removing treatment. And it is not the only enzyme promoted this way. Two others raise even more questions. Those two enzymes are serrapeptase and lumbrokinase, and this is where careful wording becomes especially important. Serrapeptase has been studied for its protein-degrading and possible anti-inflammatory effects, while lumbrokinase has attracted attention for its fibrinolytic activity. These mechanisms may sound promising, but they should not be translated into claims that either enzyme can clean the arteries, dissolve dangerous clots, or reverse atherosclerotic plaque. Evidence for specific cardiovascular outcomes remains limited, and demonstrating an effect on a laboratory marker is not the same as proving that a supplement prevents heart attacks or strokes. These enzymes may also affect processes related to clotting, making safety particularly important for people taking anticoagulant or antiplatelet medications. So before asking which enzyme is best, there is a more important question. Are we focusing on supplements while overlooking the cardiovascular risk factors we already know how to address? And this brings us to the most important point. There is no proven shortcut that simply melts away arterial plaque. Atherosclerosis develops gradually through complex changes within the artery wall, often over many years, involving lipids, inflammation, immune activity, and sometimes calcium and other material. That is very different from dissolving grease inside a pipe. Claims that fibrinogen will fall within 2 to 4 weeks or that plaque will noticeably change within 12 to 24 months after taking certain enzymes should not be presented as guaranteed timelines without strong clinical evidence. Some cardiovascular risk factors can improve with appropriate treatment and sustained lifestyle changes, and plaque can sometimes stabilize or regress modestly under evidence-based care, but results vary from person to person. The real goal is not a quick artery cleanse. It is reducing cardiovascular risk over time, and that leads to the actions that matter most. So where does that leave us? Instead of searching for a supplement that promises to clean the arteries, the stronger foundation is to manage the cardiovascular risk factors we can actually influence. That means building a sustainable eating pattern, staying physically active within your abilities, avoiding smoking, managing blood pressure, cholesterol, and blood sugar when necessary, and working with qualified healthcare professionals to understand your individual risk. Nattokinase, serrapeptase, lumbrokinase, or other supplements should never be treated as automatic substitutes for proven medical care. This is especially important if you take anticoagulants, antiplatelet drugs, or other prescription medications, because supplements that affect clotting may create unwanted interactions or bleeding risks. Never stop or replace prescribed medication on your own. The lasting lesson is simple. Protecting your arteries is rarely about one miracle ingredient. It is about consistent, evidence-based choices made over time.